Hi, good morning, everyone. Peripheral artery disease is a chronic atherosclerotic disease that remains underdiagnosed, as only 10 to 30% of all PAD patients have symptoms and affects almost 220 million people worldwide. PAD is not only associated with limb-threatening complication requiring amputation, but also a harbinger of cerebrovascular and CAD. Moreover, mortality associated with coronary artery disease and PAD remains much higher than CAD alone. Despite the cardiovascular risk factors associated with PAD, the goal-directed medical therapy for PAD remains underutilized compared to its coronary counterparts. There are several medical therapies that exist to reduce cardiovascular mortality and to prevent progression of disease and limb loss among patients. These include cholesterol reduction, antiplatelets, anticoagulation. In the subsequent slides, I'm going to go through all these based on the guidelines and the evidence that exists. In terms of these statins, the ACC-AHA recommends all patients with symptomatic PAD to be on a high intensity statin therapy. This is a class 1A recommendation. The first randomized clinical data comes from post-hoc analysis from a Scandinavian simvastatin survival group, showed a reduced incidence of carotid bruit and claudication in the simvastatin group over a median 5-year follow-up period. Additionally, the heart protection study provided the first randomized clinical trial suggesting moderate intensity statin therapy with statin-reduced peripheral vascular disease, which was defined as non-coronary revascularization, amputation, aneurysm repair, and death from PAD by 17% in pre-specified PAD group. Additionally, statin therapy reduced the rate of all cardiovascular events in PAD with 30% reduction in coronary revascularization, a 21% reduction in major coronary events, and 26% reduction in ischemic strokes. In terms of ezetimibe, the ACC-AHA cholesterol guidelines recommend the use of ezetimibe in the management of very high-risk patients with LDL that is greater than 70, despite maximally tolerated statin therapies such as PAD group. The IMPROVE-IT trial randomized patients with recent ACS to receive either ezetimibe or placebo, along with a moderate intensity statin therapy. High-risk patients categorized by TIMI score appear to obtain the greatest reduction in future cardiovascular events from ezetimibe, and about 18% of these high-risk patients had PAD. A small randomized clinical trial by West et al. Compared femoral artery plaque burden progression between symptomatic PAD patients assigned statin therapy plus ezetimibe, and ezetimibe alone. Interestingly, the ezetimibe alone group showed progression of plaque burden, whereas the other groups remained stable, suggesting that ezetimibe without statin therapy is not sufficient in the management of PAD. In terms of the PCSK9 inhibitors, there have not yet been any studies to examine the outcome of PCSK9 inhibitors in patients specifically with PAD. The only data available comes from a subgroup analysis of 4-year trial, comparing evolocumab to placebo among patients with atherosclerotic disease, LDL greater than 70, with and without PAD. Patients with PAD had an impressive 59% reduction in LDL with evolocumab, resulting in a 3.5% absolute risk reduction in primary endpoints of cardiovascular events. Additionally, the pre-specified symptomatic PAD group also had a 42% reduction in major adverse limb events such as acute limb ischemia, major amputation, or urgent peripheral revascularization for ischemia. Now moving forward to the antiplatelet therapies such as aspirin. PAD, as you already know, is associated with an increased platelet adhesion, aggregation, and hyperexpression of surface protein P-selectin, leading to atherothrombotic complications. The ACC-AHA categorizes antiplatelet therapy as a class 1 indication for treatment of PAD. The first major data to suggest its utility in PAD was in 2002, with a meta-analysis of randomized clinical trials from the Antithrombotic Trialist Collaboration. Analysis was conducted on over 9,000 patients with PAD and showed a proportional reduction of 23% in vascular events, non-fatal MI, non-fatal stroke, or vascular death. Moreover, the CLIPS trial in 2007 evaluated low-dose aspirin among 366 patients with symptomatic and asymptomatic PAD. The trial found a 64% relative risk reduction in major vascular events, including ischemic strokes, MI, and vascular death. In terms of aspirin versus clopidogrel, single-agent antiplatelet therapy remains an ACC-AHA Class 1A recommendation. The guidelines do not recommend clopidogrel over aspirin. Clopidogrel, however, has been compared with aspirin in the Capri trial, which remains the only trial with a subgroup analysis comparing these two antiplatelet agents. There was almost a 25% reduction in the primary endpoint of vascular death, non-fatal MI, or CVA in patients with clopidogrel over aspirin. Compared with the other subsets in the trial, the pre-specified symptomatic PAD group benefited the most. The general population had only an 8.7% relative risk reduction. In terms of ticagrelor versus clopidogrel, the Plateau trial randomized patients with ACS to either clopidogrel or ticagrelor and found that ticagrelor significantly reduced the incidence of MACE at 1 year without significantly increasing the rate of major bleeding. A post-hoc subgroup analysis of this population included patients with lower extremity PAD. The reduction of cardiovascular death, MI, or stroke with ticagrelor compared with clopidogrel in PAD patients, although was numerically lower, did not reach statistical significance. Additionally, in 2017, the Euclid trial compared clopidogrel and ticagrelor in almost 14,000 symptomatic PAD patients. The primary endpoint of cardiovascular death, MI, or ischemic stroke was not statistically significantly different between these two agents. In terms of the DAPT therapy, the 2016 ACC-AHA guidelines provide a low recommendation, which is Class 2B, for use of DAPT with clopidogrel given the absence of substantial long-term evidence. A post-hoc subgroup analysis of the Charisma trial compared DAPT to aspirin monotherapy among symptomatic and asymptomatic patients with peripheral artery disease. The DAPT therapy resulted in a statistically significant 15% relative risk reduction in the primary endpoint of MI, but at the cost of increased minor bleeding. Another subgroup analysis of over 1,000 patients from Pegasus TIMI 54 trial with symptomatic PAD showed an absolute risk reduction of 4.1% in the primary endpoint of cardiovascular death, stroke, or MI for patients on DAPT compared with aspirin and placebo. A 35% relative risk reduction in critical limb ischemia, but also at the cost of increased major and minor bleeding events. In terms of the anticoagulation therapy, the pathogenesis of CLI, the most dreaded limb complication of PAD, is primary atherothromboembolic, more so than atherosclerosis alone. Our group at Sinai recently published a meta-analysis among 17,684 patients from 7 different randomized clinical trials. The addition of anticoagulation to antiplatelet therapy was compared. Primary efficacy endpoint was defined as MACE, a composite of CVD, MI, CVA, and limb events such as revascularization, amputation, and net clinical benefit. Primary safety outcome was defined as major bleeding according to the trial definition. The use of anticoagulation therapy at any dose was associated with a MACE reduction, however, at the risk of increased major bleeding. The absolute risk for MACE was 2.2% at the cost of 1.9% absolute risk increase in major bleeding. However, the low-dose anticoagulation provided a more favorable balance between ischemic reduction and increased risk of bleeding, which was 2.3 versus 1.1%, with a net clinical benefit of 1.2%. In terms of the peripheral vasodilators, also known as cilostazol, The ACC-AHA guidelines include a Class 1A recommendation to cilostazol in the treatment of symptomatic claudication. A systematic review of 15 trials showed cilostazol increases exercise tolerance compared with placebo, such as walking distance before onset of claudication. With 100 milligrams of twice a day, cilostazol improved the weighted mean walking distance by 31.41 meters. However, improvement seen with cilostazol is subtle, use associated with headaches, palpitation, diarrhea, and contraindicated in patients with heart failure. In terms of the blood pressure management, the ACC-AHA guidelines gives antihypertensive therapy a Class 1A recommendation for patients with peripheral arterial disease. A post-hoc analysis from the HOPE trial compared ramipril to placebo among 3,099 patients with PAD, and they found a significant reduction in the primary outcome of cardiovascular death, MI, or stroke in patients with clinical as well as subclinical PAD. However, a post-hoc sub-analysis of the ALL-HAT trial failed to show a significant reduction in primary endpoints of fatal or non-fatal MI and MACE with ACE inhibitors or angiotensin receptor blockers compared to other antihypertensive classes among patients with symptomatic PAD. As a result of these data, both the European Society of Cardiology and ACC-AHA guidelines give a Class 2 recommendation for ACE inhibitors or angiotensin receptor blockers for treatment of peripheral arterial disease. In terms of the lifestyle modification, such as smoking cessation and supervised exercise therapy, the ACC-AHA guidelines give pharmacological and non-pharmacological smoking cessation therapy a Class 1A recommendation for patients with PAD. Smoking is the single most modifiable risk factor for the development and progression of PAD from endothelial dysfunction leading to atherosclerosis. The ACC-AHA guidelines also provide a Class 1A recommendation for supervised exercise therapy and Class 2A for home-based exercise therapy in patients with PAD. A recent meta-analysis of exercise therapy trials found a mean difference of 82.11 meters in pain-free walking distance in addition to improvement in quality of life. A follow-up meta-analysis compared supervised exercise therapy to home-based exercise therapy. At 3 months, supervised exercise therapy was superior with a mean walking distance improvement of 210 meters in favor of supervised exercise therapy. So in conclusion, high-intensity statins, antiplatelets, exercise therapy, adequate blood pressure control, and nicotine cessation are the cornerstones and recommended as a first-line therapy for treatment of PAD. Clopidogrel monotherapy appears to be more effective than aspirin at reducing composite adverse cardiovascular events and recommended as an alternative to aspirin in patients with PAD. Depth utilizing clopidogrel reduces MACE compared to aspirin alone and also recommended as a Class 2 indication by the current guidelines. Based on the COMPASS and Voyager PAD trials, rivaroxaban plus aspirin reduces MACE and major adverse limb events in patients with PAD, although at the risk of increased bleeding. However, low-dose anticoagulation such as rivaroxaban 2.5 milligram twice a day plus aspirin appears to confer a favorable safety-efficacy ratio and can be considered in patients with low risk of bleeding. Thank you so much.